Dear ladies and gentlemen, dear colleagues, first of all, I would like to apologize that I couldn't come to Quito personally due to a severe family problem. We all know that there is interaction between mechanical forces and biologic tissues. This is the base for the principle of form follows function, which may be observed in the development of the major musculoskeletal system. Subtalar synostosis may lead to a ball and socket ankle. Herb palsy may lead to increased glenoid retroversion and posterior humerus subluxation, or neuromuscular disorders may lead to coxovalgia, and so on. Furthermore, the humeral head retroversion is very variable and is different between different ethnic groups as well. This is interesting since we all are taught to implant the humeral stem in the same manner, independent from the ethnic dependence of the patients. Again, following the principle of form follows function is the finding that glenoid retroversion is associated with torsional differences in the humerus. For these reasons, I would suggest to resect the humeral head in the individual plane of the anatomical neck to maintain individual muscle tendon balance. When we look on glenoid inclination, we know that in the normal individuum, it is indifferent. The orientation of the glenoid surface is superiorly in shoulders with a supraspinatus tendon or have a certain situation of a rotator cuff at risk. On the other hand, primary osteoarthritis typically has a glenoid inclination inferiorly that may be understood as a protection of the rotator cuff. For these reasons, I would suggest to position the glenoid according to the individual glenoid inclination angle to protect the cuff. Of course, in extreme situations such as an E3 forward glenoid, we have to take different measures and, for instance, use a reverse prosthesis and a graft. With respect to glenoid version, we know there are two different methods of measurement: Friedman's scapular body technique and glenoid vault technique. Both are depending on the level of the plane for the measurement. So you may observe that in the same individual, you may see retroversion at one level and anteversion in the other. On the other hand, again, based on the principle of form follows function, we know that glenoid retroversion in normal shoulders is much less compared to arthritic shoulders. For these reasons, I would suggest to position the glenoid according to the individual glenoid version angle up to 26 degrees to respect the individual ligament balance. When we look on the relationship of the glenoid surface and the humeral head balance according to the classification of Walch, we may find that an anatomic implant we may use in each of these situations. It depends, however, whether to use a total or a hemi, and in some of them probably we should use a reverse. So in types A and types B1 and probably also in some of B2 glenohumeral osteoarthritis, we may use a total shoulder implant. In some of them, however, we have to think of a hemi or a reverse according to the individual situation. This is an example for a glenoid version 24 degrees retro and a Walch B1 glenohumeral disbalance 3 years after implantation of a total shoulder. He has a very good clinical result, and the balance of the humeral head is well centered on the glenoid. The same patient on the right side has a hemiprosthesis since 7 years. He has a retroversion of 27 degrees, a Walch C or an extreme B2 glenoid. Again, function is very good, and the centricity of the humeral head in the neoglenoid is maintained. Another patient with a B1 glenohumeral eccentricity, 7 years after implantation of a total shoulder, with a really good clinical and functional result. No signs of glenoid loosening. And when looking on the axial views, we can state that there is a rebalancing of the humeral head well centered on the glenoid implant. There are two very important technical points. I think it's very important to protect the subchondral bone plate. For this reason, I'm using only a curette. I avoid reaming in any case. I don't use it. I think protection of the subchondral bone plate is the base for an optimum primary stability of the glenoid implantation. The second important technical point is to protect the capsulolabral complex in order to preserve at least parts of proprioception and to prevent glenohumeral instability. You see 3 arthroscopic views 1 year after implantation of a total shoulder is looking perfect to my idea. I had to go into the joint because the patient had a bad functional result due to a secondary gain problem. Some years later, she returned to my office. The problem was resolved and function was perfect. Since 12 years now, I'm using this individual technique, gathering 89 anatomic joint replacements, initially using a conventional stem cemented, and since 9 years a short stem non-cemented, combined with a killed glenoid. In total, I observed 8% of complications, of which 2 required a surgical revision. However, there was no symptomatic glenoid loosening, no humerus shaft loosening, and no glenohumeral instability. In summary, based on the principle of form follows function, the individual positioning concept includes a resection of the humeral head in the individual plane of the anatomical neck in order to preserve individual length of musculotendinous units. You have to respect the individual glenoid inclination angle to protect the rotator cuff. You should respect the individual glenoid version angle in order to protect ligamentous balance, and individual implant positioning with centric humeral head and the total shoulder is perfect, as well as individual implant positioning with eccentric Walch type B1 and some of by a B2 eccentric shoulders, because they will rebalance. The important technical points are the protection of the subchondral bone plate in order to have optimum glenoid stability, and the protection of the capsulolabral complex in order to gain glenohumeral stability. Thank you for your attention.